we have with us the moderator, Professor Soho, moderating the session, and the speaker will be Professor Takahisha Gono. Professor Ho, please.
Right, good evening, seniors and colleagues. I'm Soho from the Chinese University of Hong Kong. So it's my great honor to chair this session, myositis session of the Aplar midterm symposium. And we actually all know that interstitial lung disease is one of the most important complications of myositis, and probably particularly so in the East Asian countries because we have probably more anti-MD5 dermatomyositis. And I think this is a very important topic, interstitial lung disease associated with IIM. Right, so tonight is a great honor to have Professor Takahisha Gono to talk to us on this topic. So Dr. Gono is an associate professor of the Department of Allergy and Rheumatology at the Nippon Medical School Graduate School of Medicine. So he obtained an MD from the Yamanashi University and PhD from the Shinshu University Graduate School. So actually in the field of myositis, I think Dr. Gono requires no further introduction. He has published quite extensively, including several landmark papers on MD5 dermatomyositis, as well as lung disease associated with myositis. So without further ado, please welcome Dr. Gono.
Thank you for your introduction, Professor Hoso. Hello, everyone. I'd like to thank the people involved in this symposium for giving me the opportunity to present my lecture. So I'd like to talk about recent advances in idiopathic inflammatory myopathies associated with interstitial lung disease. This is my disclosure. This slide shows the outline for today's my presentation. At first, I will discuss epidemiology and clinical manifestations of myositis associated with interstitial lung disease. Next, what are the prognostic factors? Then, how to treat and stratify patients of myositis associated with interstitial lung disease. After that, how to monitor the disease status of ILD. Finally, I will share my perspective in the future on this field. According to a meta-analysis, the pooled prevalence of ILD, as you can see the figure, the prevalence of ILD is 41%. So the prevalence of ILD is higher in DM and clinically amyosic DM than in PM. The prevalence of ILD depends on geographical regions. For example, 50% in Asia, 26% Europe, and 23% in America. So as you can understand, most of patients have the complication of ILD in myositis. This slide shows clinical manifestations of myositis is highly variable among myositis patients. So IIM subcategorized into 4 groups: DM, IMNM, IBM, and overlap myositis. As you can see, the myositis-specific autoantibodies or myositis-associated autoantibodies are highly related to clinical manifestation of myositis. So, in terms of ILD, MSA, anti-ALS, MD5, and MAA, UNP, COO, PMSL are strongly related of the development of ILD. Let's look at this table, especially anti-ALS, anti-synthase, and anti-MD5 antibody is strongly related to the development of ILD in myositis. The ILD pattern on computed tomography is highly variable, and let's look at this table. There are a lot of differences in the ILD pattern on CT between anti-synthase antibody positive ILD and anti-MD5 positive ILD. For example, NSIP is higher in anti-ARS positive patients. On the other hand, OP and AIP is higher in anti-MD5 positive ILD. And reticulation, traction bronchiectasis is also higher in anti-ARS positive ILD. So let's look at the upper right figure in anti-synthesis autoantibody positive ILD. The lung regions exist at the base or lower lobes of the lungs along bronchovascular bundle. And reticulation traction bronchiectasis is also found with GGA or consolidation. On the other hand, anti-MD5 antibodies, the lung regions exist at the peripheral area or subpleural area with consolidation on the lower lobes or random GGO distributed. Next, what is a prognostic factor? Actually, there are many prognostic factors in myositis. So how do we use them? How do we discriminate those prognostic factors? Before we start immunosuppressive induction therapy, we should predict the prognosis in individual patient with myositis ILD. So you can understand many prognostic factors before the determination of the initial treatment. This slide shows conventional prognostic markers. Older age, male, DM, and delay in diagnosis is associated with poor prognosis. In terms of clinical features of ILD, acute subacute home, progressive ILD over 3 months, lower pulmonary function, and corticosteroid resistance ILD are poor prognosis, related to poor prognosis factors. Conventional peripheral blood biomarkers include increased neutrophil lymphocyte ratio, increase of inflammatory markers, and pneumoproteins such as KEL6 and SPD, and presence of anti-MD5, PL7, PL2, or Rho52. So regarding radiological findings of CT, extent of ILD, which occupy over 20%, UIP pattern, or consolidation of GG pattern, random GGA, those factors are related to anti-MD5 autoantibodies, and higher score composed of consolidation and GGA strongly closely associated with a poor prognosis. Many prognosis factors. Next, I would like to show you experimental prognostic markers. So in clinical immune cells in peripheral blood, increased CD3 negative, CD19 positive cells are independent risk factor for the development of ILD in patients with anti-synthesis. On the other hand, activate CD45 are positive, HAD are positive, CD8 positive T cells with decreased CD56 dim natural killer cells are associated with a rapidly progressive ILD, which is usually anti-MD5 positive or antibody positive. In addition, serum or plasma biomarkers, those biomarkers are related to activated status of immune cells, especially macrophages or monocytes. So the remaining novel biomarkers are reported. So, but it is time-consuming measure those experimental biomarkers. It is difficult for physicians to adapt those biomarkers to predict prognosis. So, how do we use them? How do we use prognosis factors? The answer is next. The answer is shown in next slide, partly. Sorry. So This is from JAMI cohort. JAMI cohort is enrolling about 500,000 patients with incident cases, myositis-associated interstitial lung disease. So the aim of the JAMI cohort study is to identify independent prognosis factor. So in this study, the most important, most impact prognosis factor is the presence of anti-MD5. So we focus on biomarkers, including anti-MD5 or antibodies. So we named MCK model. So we create MCK model focusing on biomarkers. So this model composed of two biomarkers, CRP, KEL6, in addition to the presence or absence of anti-MD5 or antibodies. We divided patients into 3 groups as the number of risk scores: low, moderate, and high. We separated 3 groups. As you can see, we successfully differentiated survival rates based on the risk factors. So, which is replicated in the different independent cohort. In addition, the similar model is reported from China. This model, FLAIR score. FLAIR score is composed of the presence of RP-LD or non-RP-LD and HRCT score, the levels of anti-MD5, ferritin, and LDH. Those scores divided patients into 3 groups: 0.24 score, low, 5 to 9 in medium risk, 10 to 13 in high risk group. So as you can see, the survival rate successfully divided each patient. In low risk score, 1 year survival rate 100%. In medium risk group, 80%. In the high risk score, 30%. So independent cohort, this FLAIR model successfully identify, stratify patients in myositis-associated ILD. We show, MCK model, this model, FLAIR model, should be validated to evaluate the applicability to different across world. Next, I'd like to talk about how to treat and stratify patient. Actually, there has been little evidence regarding treatment of myositis ILD because this disease is rarity and diversity and have difficulties in conducting a clinical trial. However, in the past few years, there have been treatment recommendations and past expert opinions provided by academic societies. I will show you them. The first, this is from British Society of Rheumatology. These recommendations divided ILD into 2 forms of ILD, RP-ILD and chronic ILD. In RP-ILD, calcium inhibitor conjunction with corticosteroid should be considered. In addition, cyclophosphamide or rituximab should be added as early as possible as induction therapy. On the other hand, in chronic ILD, corticosteroid with or without one single DMARD, such as a thiopurine calcium inhibitor or MMF. And in refractory cases, rituximab or cyclophosphamide should be considered. Next, this is expert perspective in refractory myositis-associated, which is provided by American College of Rheumatology. So this algorithm divided 2 groups, moderate ILD and severe ILD. Severe ILD was defined by percent predicted FVC less than 70%, TLCO less than 55%, or HRCT extent over 20%. So in moderate ILD, calcineurin inhibitor or MM should be considered in conjunction with corticosteroid. If the treatment response is poor, so we should consider adding rituximab or cyclophosphamide. In severe ILD, at first, cyclophosphamide or rituximab should be considered. This is from Spanish group. This algorithm is specific for anti-MD5 positive associated RP-ILD. At first, the combination therapy with glucocorticoid plus calcium inhibitor or triple combination therapy, including cyclophosphamide. If calcium inhibitor is contraindicated, it should be avoided. Instead of calcium inhibitor, rituximab or MMF should be considered. If the treatment response is poor, so adding other immunosuppressants such as tofacitinib, or we should consider plasmapheresis or ECMO to prepare for consultation of lung transplantation. So lastly, this is from Japanese College of Rheumatology and Japanese Respiratory Society. This algorithm was composed by disease behavior, acute subacute home or chronic progressive and chronic non-progressive, and MSA profile, MD5 positive, anti-ALS positive, double negative. In addition, physician can consider other prognosis factor as shown in this slide. Additionally, recently, there are several studies which conduct identification of homogeneous group in myositis ILD because we need to conduct personal medicine for individual patients in myositis associated ILD. So from JAMI cohort, we can identify 6 groups separately. So group 1, group 2 is anti-MD5 negative, but has no requirement of oxygen. Those groups are relatively, prognosis is relatively good. On the other hand, cluster 5, 6, all patients require supplements oxygen, regardless of MSA profile. Those patients' prognosis is worse. So in the middle group, group 3, group 4, all patients have anti-MD5 positive. Those patients are relatively worse, prognosis worse. So unfortunately, we failed to identify group which the better response to the initial triple combination therapy than the other therapy. So lastly, I'd like to talk about how to monitor the disease status of ILD. So how to monitor status of ILD? So physicians should comprehensively assess the ILD based on respiratory symptom, SpO2, physical examination, pulmonary function testing, lung imaging, and biomarkers. Actually, some biomarkers play some important role in the evaluation of disease activity, the severity. KL6 is a specific for the lungs. KL6 sometimes increase of KL6 is happen in other disease, but KL6 increase associated with anti-synthesis or antibody. Anti-MD5 is also correlated with the disease activity, so it's very useful to monitor those biomarkers. So this slide shows the treatment goal based on the disease behavior. We should set the treatment goal in individual patients. For example, acute, subacute home ILD, the treatment goal is to remission or life-saving. And chronic ILD, so the goal is to prevent acute exacerbation or recurrence and maintain or stabilize the ILD. Finally, I'd like to share my further perspective. So at first, I define and evaluate accuracy of risk stratification model for mortality. Next, I identify pathology more clearly and biomarkers measured in daily practice. Then we need to develop novel target therapy, especially for respiratory cases, including anti-MD5 or anti-MD5 antibody, ILD, despite triple combination therapy, or anti-ALS positive ILD with recurrence or progression of ILD. So finally, we need to elucidate methods for monitoring disease activity and progression accurately. So we need to collaborate research investigator over the world to solve those issues. Thank you for your attention.
Thank you, Dr. Gono, for the very insightful and comprehensive talk. So now the floor is open for questions.